Good morning, everybody. Dignitaries of the dais and all my colleagues in the faculty, junior residents. It's my pleasure to present you a CCR today focused on rare diseases. And I'll just brief you on what the Institute of Rare Disease and the Institute of the Mahatma Gandhi Children's Hospital is concerned. When I joined this institute, I was given two responsibilities exclusively. One was to develop the Mahatma Gandhi Children's Hospital near the J. Kellon Hospital, and the other Institute of Rare Disease. So these are the two institutions that I was supposed to develop, apart from running the Department of Pediatrics. I've been into pediatrics for almost 4 decades, much before most of these residents were ever born, or most of the young faculty was born. So it was much easier for me to really take care of the Mahatma Gandhi Children's Hospital, and I'm more than happy and proud to say we are the fastest growing pediatric hospital of the city, having touched nearly 15,000 OPDs in the last 13 months. And one thing very important, all these patients who visit us are not part of any scheme. It's out of the pocket expense that they pay in cash. So it's a big achievement, especially when insurances have taken a big place in the medical management. We have covered almost 900 plus indoor patients, and we had a target of at least a 10% growth from one year to the other year, because unless you have targets, you are never really focused on what are you trying to achieve. It's just not coming and going into from the hospital. So in January 24, we touched a figure of 856 OPDs, and this January, we are up by 18%, which is beyond what we thought and what we expected or what we planned. So it was easy for Mahatma Gandhi Children's Hospital to do well. And from there on, we went on to the Institute of Rare, my focus was on the Institute of Rare Disease. Initially, I thought I'll move very fast the way I moved with the Mahatma Gandhi Children's Hospital. Developed interdepartmental connectivity, developed subspecialties, contacted people. But somehow, after 2 months of being in this program, I realized it's not really doing as good as expected. And that's where we did a revision in the strategy. Our focus now became developing a clinical database first. We decided to move slightly slower than what initially thought of. And so we decided to develop a clinical database. And I'm more than happy to say that in the last 6 months, our rare disease registry has seen 547 patients, which includes both rare and ultra rare. Ultra rare is only 2 patients per 100,000. So 2 patients in 1 lakh population. So we have a fairly good number of rare and ultra rare patients. And these 547 OPD visits includes new cases as well as revisits. And some of these rare cases are the only one in the country. For example, a female DMD, because an X-linked disorder would normally be seen only in males, and we still have a girl who has Duchenne muscular dystrophy, which was a very unusual thing. And we have consistently maintained the pace of increasing the number of OPD visits with the rare disease patients too. The Mahatma Gandhi Children's Hospital provides almost every facility that any pediatric hospital needs to, includes the emergency, the PICU, the NICU, and the general ward. Our focus in the academic sector was equally good, and we had 12 publications which were both globally recognized publications, and we've been there in the Alzheimer's Global Medical Genetics, which is one of the most prestigious journal from the genetic perspective. We also had our students presenting 22 posters in various international and national meetings, and that is again something which gives a big credit to the team. My team with Vaibhav and Tushita, we worked on developing the clinical manual on rare disease. This is a clinical manual which is going to train the primary care physicians, pediatricians, and internists in the field of rare disease. And the World Pediatric Association has accepted it as their training module, which speaks high of the quality that Mahatma Gandhi has been able to achieve. So that's something which brings Mahatma Gandhi into the focus. We do almost every procedure that's possible in the pediatric segment. And when I said we did a revision, the strategy of promoting rare disease, so developed a clinical database. Number two, we positioned ourselves both at the national and the global level using individual credibility, because what happens is the institutional credibility will take time because our departmental activities are moving slower. So we decided to use our individual credibility to enhance the presence of the Rare Disease Institute at Mahatma Gandhi, and thus I was nominated as the chairman of the task force by the World Pediatric Association to run rare diseases. Then we did the international conference, which was International Conference of Birth Defects. Then we've been in the Bengal Business Summit. We've also been represented with different countries, including the Swedish Embassy, which invited us to be there as part of the Indo-US Health Summit. And then the American organization, which is the most old organization in the field of rare disease, the National Organization of Rare Disease, invited me for a guest oration and also represented this institute in the Latin American meeting. We have major future plans, though they are going to be done in a phased out manner. We want to develop a multi-specialty program. We also focus on pediatric and adult rare disease units, because you need to have a dedicated section for early intervention in children and long-term care for adults, telemedicine and outreach clinics. The goal is to reduce diagnostic delays, offer specialized treatment, and enhance long-term patient outcomes. We also intend to develop a rare disease innovation and clinical trials program, and the intent is to become a global leader in rare disease care and research, develop policies and advocacy programs, and enhance awareness, patient education, and community engagement. Thank you.
A very good morning, respected faculties, seniors.
Just a minute.
Yes.
This manual, if we have developed on our own and it is not a copy from another institution, then please get it copyrighted. I'll send you the contact details of Dr. Shweta Mangal. She is the in charge of the IPR cell. And my request to other departments also, if any departments have developed any protocols, any manuals which are our own, then please get them copyrighted. Can get in touch with IPR cell. They will help and they will do all the formalities.
A very good morning, respected faculties, seniors, and my colleagues. Today I, Dr. Shipra Majumdar, third year pediatric resident, shall be presenting a case about an 8-year boy with hemoptysis. The informant here is mother. An 8-year boy presented with complaints of fever for 2 days, cough with blood streak in sputum for 2 days, paleness of body for 1 day, and shortness of breath for 6 hours. On initial assessment, pallor was present. There was increased work of breathing, and the GCS was 11/15. On taking the vital parameters, the heart rate was 176 beats per minute, which suggests tachycardia. The patient had tachypnea with a respiratory rate of 74 breaths per minute. The blood pressure was 98/78 millimeters of mercury. The saturation was 80% on room air, and the temperature was 102 degrees Fahrenheit. The initial assessment gave us an overall picture of a life-threatening situation. The patient was immediately intubated and taken on mechanical ventilation. Alongside, a detailed history and examination was done. The child presented with fever for 2 days as the primary complaint, which had been ongoing. It was abrupt in onset with a moderate grade, intermittent with 1 to 2 spikes in a day, each spike lasting for 2 to 3 hours. It was not associated with chills and rigor or rash, and it relieved on taking medications. Cough was present for 2 days. It was productive. Sputum was thin in consistency, blood tinged in 2 episodes, and bright red in color. It was not associated with chest pain. Pallor was set within a day. Shortness of breath was sudden in onset and rapidly progressive. Patient had a significant past history. The child was asymptomatic until the age of 7 years. His first episode occurred in November of 2023 when he presented with fever, cough, cold, pallor, and generalized weakness. He was treated for upper respiratory tract infection and anemia and received his first blood transfusion at a PHC OPD visit. Patient remained asymptomatic for 3 months. Then he had a second episode in March of 2024 with similar complaints. On investigating, his hemoglobin was low, the mean corpuscular volume was 58.4 femtoliters, and he had a microcytic hypochromic picture on peripheral blood film. He had raised lactate dehydrogenase levels, a normal high performance liquid chromatography, low serum iron and high total iron binding capacity. He required his second blood transfusion and remained asymptomatic for the next few months. The third episode occurred in 2024 of August of 2024 with recurrent fever, weakness and pallor. Patient was admitted at a tertiary care hospital in Jaipur. Investigations were done and revealed severe anemia with raised LDH, high total iron binding capacity, low serum iron levels, normal vitamin B12 and folic acid levels. He required his third blood transfusion at that time. By September 2024, he developed new symptoms of shortness of breath and blood-tinged sputum. On investigating, his hemoglobin was again low. Bone marrow aspiration biopsy was done for further evaluation and showed a dimorphic anemia. Sputum for CB0 was negative. Endomysial IgA antibodies and TTG IgA were also negative, thus ruling out celiac disease. Due to respiratory distress, he was placed on BiPAP support. He required his fourth blood transfusion and was treated as a case of chronic anemia with recurrent infections. Patient had no history of rash and joint pain. There was no history of passage of red-colored urine. There was no history of bleeding from other sides. No positive history of COX contact. No history of significant weight loss or no history of prolonged immobilization. The birth history was normal. The child was immunized for age. BCG mark was present on left upper arm. The developmental history was appropriate for age. The child studies in third grade with a good scholastic performance. The calorie and protein intake was calculated as per the dietary recall history. Patient had a calorie deficit of 10% and protein deficit of 16%. Child is a product of non-consanguineous marriage. There is no history of similar illness in the family on either the paternal or maternal side. In this 3-generational pedigree chart, we can see the affected child is a younger sibling and no significant history in the last 2 generations can be seen. General physical examination was performed after securing the airway. Patient was on mechanical ventilation. Patient had a fever of 102 degrees Fahrenheit. Temperature was taken in right axilla using a digital thermometer. Had tachycardia with a heart rate of 176 beats per minute. Peripheral pulses were well palpable, regular. No radial delay or no radiofemoral delay. The blood pressure was 98 by 68 millimeters of mercury. It was taken in right upper limb and supine using the auscultatory method. It lied between 5th and 50th centile. There was no significant difference in all 4 limbs. The saturation was 94% and the capillary refill time was less than 3 seconds. On anthropometric assessment, the weight, height and body mass index lied between the 10th and 25th centile for age, which is normal according to the IAP WHO growth charts. Patient had pallor in the lower palpebral conjunctiva, in the palmar creases, nail beds. Otherwise, clubbing, edema, icterus, cyanosis and lymphadenopathy was absent. Moving to systemic examination, on respiratory system examination, patient was on mechanical ventilation. There were no scar marks, chest wall deformities, and the chest movements were symmetrical. On palpation, the chest movements were equal on both the sides. The percussion notes were dull on both sides. On auscultation, breath sounds were reduced on both the sides, and coarse crepitations were heard bilaterally and diffuse across the chest. Since the patient was intubated and on sedation, neurological assessment was done using the 4 score, the full outline of unresponsive score. It assesses 4 main domains: the eye response, motor response, brainstem reflexes, and respiration, each scored from 0 to 4, with a total score ranging from 0 to 16. Our patient's score was 5 by 16. On cardiovascular system examination, the heart sounds were normal. Patient had tachycardia. There were no added sounds or audible murmur. The abdominal examination was normal. So to summarize, we have a 8-year-old male child with history of anemia requiring recurrent blood transfusion, investigation suggestive of iron deficiency anemia with a normal HPLC, and bone marrow biopsy picture showing functional marrow with dimorphic anemia, with a past history of 2 episodes of hemoptysis, who presented to us currently with a life-threatening pulmonary hemorrhage and acute respiratory failure. Now, with the above said summary, I would like to ask the audience what all differentials can we think of. So we did that, and we'll be describing that in the emergency management. It will come later on in the later section. So, any possibilities? Okay. So, yeah, we begin with infections as a primary possibility, which can contribute to pulmonary hemorrhage due to vascular inflammation, necrosis, and capillary damage. The two key infections to consider are tuberculosis and pneumonia. Next, we considered coagulopathies, as rightly said by my colleague Dr. Nishtha, as patient had mild derangement on coagulation profile on day 1. Moving further, we examined the autoimmune conditions which can cause pulmonary hemorrhage due to immune-mediated endothelial injury and vasculitis. The key autoimmune conditions we considered here were Good-Pasteur syndrome, systemic lupus erythematosus, and Wegener's granulomatosis. Finally, we arrive at pulmonary hemosiderosis, a group of disorders characterized by recurrent alveolar hemorrhage, a prolonged history of anemia, and hemoptysis with iron deposition in lung tissue. Proceeding with the investigations, complete blood count picture on day 1 was suggestive of severe anemia with microcytic hypochromic red cell picture following massive pulmonary hemorrhage, along with marked leukocytosis with neutrophilic predominance, likely due to an underlying infection or stress response. The child exhibited prolonged PT-INR and APTT on admission, suggesting coagulopathy, likely secondary to the massive pulmonary hemorrhage. The C-reactive protein levels were high. The renal and liver functions were preserved. Urine routine examination was done and reported normal. Now I would like to invite Dr. Vaibhav Upadhyay sir to discuss the emergency and critical care management.
Good morning, everyone. Thank you, Dr. Shipra. So, when we received the patient in emergency, the airway was non-maintainable. So, we intubated the child. As soon as we intubated the child, there was a brisk stream of red blood through the ET tube. And you can see in the picture, there was a blood loss of more than 600 ml. So we have given the intravenous tranexamic acid at the rate of 20 mg per kg and intratracheal adrenaline at the rate of 1 ml per kg of 1:10,000 dilution. After that, we have taken the child on mechanical ventilation on pressure.
Sorry to interrupt, but if you see fresh red blood in the endotracheal tube, would you consider the possibility of an arteriovenous or a vascular malformation in the tracheobronchial tree? Because all the diseases which you described, as far as I know and remember, they would not cause large amount of fresh red blood in the respiratory tract.
Yes, sir. So we thought about the AV malformations, but the history and the examination was not suggesting that, so that's why we have kept it on the lower side. Yes. So the child was kept on pressure assist control mode, and peak inspiratory pressure was 18 centimeter of water, and positive end expiratory pressure was 7 centimeter of water. The rate was 35 per minute, and FiO2 was 80%. We did a arterial blood gas which showed pH was 7.15, PCO2 was high. Thank you. PCO2 was high, which was 68 mmHg. Partial pressure of oxygenation was 43.3 mmHg. Bicarbonate was 21 millimole per liter. Lactate was 5.2 millimole per liter, which was interpreted as metabolic and respiratory acidosis. So we calculated the oxygenation index, which was 24. So formula for oxygenation index is mean airway pressure multiplied by the fraction of inspired oxygenation divided by partial pressure of oxygenation into 100. So when the oxygenation index is 16 or more than 16, it is suggestive of severe ARDS. After that, we have done the point of care ultrasound. So before starting the video, I'll explain what we are going to see in this. We are going to see two things. The one is B lines. The B lines are the longitudinal hyperechoic lines, and which are rocket-like comet tail appearance will be there, starting from the pleural line and coming down. The other thing we will see is shred sign, in which the pleura is the broken, and there will be hypoechoic lesion, which is suggestive of consolidation. So let's play this video. So these are the rib shadows. These are the rib shadows. In between there are multiple B lines are there, and this is the hypoechoic area and the broken pleura. And you can see there are these star-like things, the shimmering effect and the the bulb is flickering like that, which shows the consolidations. So what we got in interpretation, there are more than 3 B lines in a single window, which shows the pulmonary edema is there and shred sign is present, which shows there's a underlying consolidation is there. Then on further assessment, we did the cardiac screening and the fluid assessment status. So for the first picture, there's a 4-chamber cardiac view, so in which we found the contractility was good. And in the second picture, you can see this is the right atrium, and from the 2 centimeter from the right atrium, we can see that IVC, inferior vena cava, is collapsible, and this is the M mode for the same view. So there is no much variability between the inspiratory and expiratory phase, which shows the fluid deficit. And then we calculated the ejection fraction. So this is the left ventricle, this is the right parasternal long axis view. So this is the left ventricle, and along the left ventricle we have calculated the end systolic and end diastolic volume. So by which we got the ejection fraction of 55%, which is normal for this patient. So after the assessment, we noted the issues, and according to that we intervened. So first was hypovolemia, for which we gave the intravenous normal saline bolus at the rate of 20 ml per kg. For severe anemia, we gave the intravenous PRBC transfusion at the rate of 15 ml per kg. For deranged coagulation profile, we gave intravenous fresh frozen plasma at the rate of 15 ml per kg. For sepsis, we have started intravenous paracetamol at the rate of 10 ml per kg, intravenous cefotaxime for at the rate of 50 mg per kg, and intravenous amikacin at the rate of 15 mg per kg. For diffuse alveolar hemorrhage, we gave intravenous methylprednisolone at the rate of 30 mg per kg per day, and intravenous platelet transfusion at the rate of 15 ml per kg was done. After stabilization of the patient, we did a mini bronchoalveolar lavage, which is a blind and non-bronchoscopic procedure, which obtains the sample from the lower respiratory tract of the patient on ventilator. So this is the picture of the sample which we sent to the Department of Pathology at Mahatma Gandhi Hospital. On that note, I would like to invite my colleague from Department of Pathology, Dr. Sonam Arya.
Like when you intubated, you had 600 ml of blood collected. So how it all continued, for how long it continued? That's what I want.
Okay, yes sir. So
because that might have caused some difficulty in ventilation, and some of the consolidation could be because of that also.
Yes sir, so that we have covered in the further course of the hospital, but it was the bleeding was continued for 4 to 5 days. Even on the second day it was little decreased, but on the third day again the pulmonary bleed was too much.
So you could continue to ventilate, and the
yes
were okay?
Yeah, we have continued this sir. Yeah, it required, the oxygenation index was too high for initial 2-3 days, then later it decreased after the specific management was started, sir. Sir, the plateau, sir, we have kept the child on pressure assist control. So we keep on pressure assist control because the one is it was a ARDS like clinical syndrome. So that's why we avoided the volume control, and the for pressure assist control, it's easy for our residents to see, because in flow scaler when it touches the 0 to, there will be the delta pressure we can get directly from the flow scaler. So target driving pressure we can keep. So that's why, so plateau pressure we used to get when we keep the child on the volume control mode.
That was the lowest pH which you had stored.
Yes sir, that was later it improved. Yes sir, that we have covered in the course of the hospital, sir.
We have a plain X-ray at this time, and a good X-ray of the chest.
Yes sir.
You have concluded diffuse alveolar hemorrhage
Yes,
as
sir.
the cause of this hemoptysis.
Yes sir.
It would be nice to see a plain X-ray to show what exactly, and that things like bronchiectasis or a pneumonic patch or some plain ordinary things that could also be responsible, a tuberculous cavity. those things could have been seen in the X-ray?
Yes, sir. We have sent a requisition for X-ray immediately, but while the X-ray technician comes and takes a X-ray and film comes, by that time we do the focus assessment and we can see the lung status till then. So we got the X-ray film, which Dr. Rishabh will discuss.
Good morning to all the respected teachers and my fellow colleagues. I would like to discuss cytopathological findings. So grossly we received 5 ml bile fluid, which is reddish in color and hemorrhagic in appearance. We centrifused the sample at 2000 rpm for 10 minutes and we made the smear from the sediment. So talking about cytological examination, smear was mainly hemorrhagic, showing alveolar macrophages. These arrowed cell showing alveolar macrophage in the microscopic picture. There are several causes of hemorrhagic pulmonary lavage, like diffuse alveolar hemorrhage, infections like pneumonia, TB, cystic fibrosis, bronchiectasis, various immune disorders like vasculitis, bleeding disorders like thrombocytopenia, DIC, congestive cardiac failure, various drugs including cocaine, and idiopathic pulmonary hemorrhage. Now subsequently we put pearl stain, which is a special type of stain to demonstrate the iron granules. With the help of pearl stain, we find out that the macrophages were hemosiderin laden or not. So the staining result came out to be positive in this case. As we see, these in this microscopic picture, these arrowed cells are hemosiderin laden macrophages in the background of RBCs. Hemosiderin laden macrophages can be seen in various conditions like diffuse alveolar hemorrhage, diffuse interstitial pulmonary disease, idiopathic pulmonary fibrosis, and bronchopulmonary dysplasia. Then we calculated Goldie score, which is a semi-quantitative method of assessing the hemosiderin content of alveolar macrophages. So on a high power field, we counted 100 alveolar macrophages, and then we given a score between 0 to 4 to each alveolar macrophage, and then the total score of 100 alveolar macrophage, if came more than 100, then it is suggestive of severe diffuse alveolar hemorrhage, and if it is in between 20 to 100, it is suggestive of mild to moderate diffuse alveolar hemorrhage. As we see in this picture, most of the alveolar macrophages is scoring 2 or 3. So in our case, Goldie score came out to be 280. So on the basis of all these findings, and when we correlate it with clinical findings, our final impression was that bronchoalveolar lavage mainly show hemosiderin laden macrophages consistent with severe diffuse alveolar hemorrhage. Thank you.
Bacterial and fungal cultures of the bowel sample were negative. A chest radiograph and CT chest was also done for the patient since he presented with acute respiratory failure, and the findings of which will be discussed by my colleague Dr. Hrishabh Meena from Department of Radiodiagnosis.
Thank you, Dr. Shipra. Good morning, everyone. I'm Dr. Hrishabh, resident radiodiagnosis. I'll be discussing the radiological findings in this case. So this is an AP view chest radiograph of this patient, taken with clinical history of hemoptysis, showing haziness in bilateral lung fields, predominantly in bilateral upper and middle lung zones, right more than left. However, bilateral CP angles appear clear, hence no evidence of pleural effusion is seen, and there is endotracheal tube seen. HRCT and pulmonary angiography of this patient was done in our department after 8 days. These are the HRCT axial cut sections showing complete collapse, consolidation of left lower lobe along with patchy areas of consolidation with surrounding ground glass opacities in bilateral lung fields, predominantly in bilateral upper lobes and in apical segment of right lower lobe. There is also evidence of reticulations and septal thickening seen. This is an axial and coronal cut section of the pulmonary angiography where both the pulmonary arteries and their branches appear normal with no filling defect seen. The caliber of the main pulmonary artery was also normal. No evidence of pulmonary thromboembolism, aneurysm, malformation or active leakage was seen. To summarize the findings, areas of ground glass haziness with reticulation, septal thickening are seen in both lungs, predominantly in its upper and lower lobes, suggestive of pulmonary hemorrhage. Large area of consolidation is seen in left lower lobe. pulmonary CT angiography was normal. Now I would like to ask Dr. Shipra to continue with the presentation.
For the benefit of the non-radiology residents here, please explain how do you differentiate on HRCT between collapse and consolidation?
Sir, consolidation is usually filled with any kind of fluid. It can be blood tinged, it can be pus tinged. And in collapse, sir, there is a complete volume loss of the lung seen.
On this, how would you differentiate between that is theoretical.
Right, sir.
On the HRCT, how do you differentiate, how do you say whether it is collapse or consolidation?
Sir, hyperdense lesion is seen, then it's consolidation. And sir, if there is a reduced volume of particular lung lobe, then it is.
Sir, in consolidation, we will usually get an air bronchogram, which is like air-filled spaces which are like surrounded by the fluid in the alveoli. So we see the bronchial tree within the area, that is basically a consolidation. Collapse is usually associated with loss of volume, so there will be mediastinal shift, raised diaphragm, and there can be combination of both also sometimes, consolidation as well as collapse. Yeah.
So is this consolidation?
So it had element of both actually, consolidation as well as collapse. Yeah.
But there is no air there.
There is no air, but I think the cuts below they had a air bronchogram.
Right. Thank you.
With what diagnosis in mind CT pulmonary angio was requested? What did you have in mind when you asked for a CT pulmonary angio?
We were all looking for a vascular malformation for sure. And,
yeah, because if you are thinking of a pulmonary disease, then HRCT probably would be enough. The very fact that you have asked for CT pulmonary angio means that you had a vascular lesion in mind.
Yeah, because again, we just wanted to be very safe on this case.
All right. Thank you so much, Dr. Shipra. Please.
Thank you so much, Dr. Rishab. Other specific investigations were carried out. Immunological workup was done and was negative. Respiratory biofire panel for viral infections was done and was negative. Coagulation factor assay was sent for the patient and reported normal. Von Willebrand factor was sent and reported normal. Now to summarize again, we have an 8-year-old male child with recurrent anemia requiring recurrent blood transfusions, was evaluated for suspected iron deficiency. He had a history of 2 prior episodes of hemoptysis and presented to us with life-threatening pulmonary hemorrhage and acute respiratory failure. Comprehensive workup was done. Autoimmune profile was negative. Respiratory biofire was done and it reported negative. Tuberculosis workup was negative and the coagulation profile was normal. Radiological findings were suggestive of pulmonary hemorrhage with consolidation, and the bronchoalveolar lavage cytology was suggestive of severe diffuse alveolar hemorrhage. All other possibilities were ruled out, and since this child had a prolonged history of anemia, recurrent hemoptysis, and a chest radiograph indicating diffuse alveolar hemorrhage, as well as bronchoalveolar lavage findings suggestive of hemosiderin-laden macrophages, we narrowed down to the diagnosis of pulmonary hemosiderosis. Pulmonary hemosiderosis has 3 main groups. Group A is associated with Goodpasture syndrome. It is an autoimmune condition caused by glomerular basement membrane antibodies. Kidney and lung involvement is seen in the form of glomerulonephritis and diffuse alveolar hemorrhage respectively. Group B has ANCA-associated vasculitis. A positive C-ANCA or P-ANCA confirms the association of it. Group C has idiopathic pulmonary hemosiderosis. It is often seen with presentation of recurrent hemoptysis and anemia. Bile cytology confirms with presence of hemosiderin-laden macrophages and makes it the diagnosis of exclusion. In our patient, the anti-GBM antibodies were negative, thus ruling out Goodpasture syndrome. The C-ANCA and P-ANCA antibodies were reported negative, thus ruling out ANCA-associated vasculitis. And since the bile cytology was suggestive of hemosiderin-laden macrophages, our final diagnosis of idiopathic pulmonary hemosiderosis was made. Now coming to the course in hospital. This slide illustrates the 7-day clinical progression focusing on oxygenation index, hemoglobin levels, bleeding severity, transfusions, and ventilatory strategies. On day 1, the patient had severe respiratory distress with a high oxygenation index of 24 and active bleeding requiring PRBC and FFP transfusion, which is denoted here by the red and yellow drops. High dose of the patient was taken on lung protective ventilatory methods. High dose of methylprednisolone with 30 mg per kg was started, which led to a transient decrease in the bleeding by day 2. However, on day 3, bleeding worsened, requiring again a second PRBC and FFP transfusion. Intensified immunosuppression with cyclophosphamide with a dose of 2 mg per kg per day with injection mesna was started. From day 5 onwards, prone positioning was introduced. It improved oxygenation. On day 6, the patient was extubated and taken on BiPAP support, further reducing the ventilator dependence. Oxygenation continued to improve, bleeding episodes diminished, and hemoglobin levels stabilized, allowing for the patient's transfer to MGH PICU for further investigations. These are the sequential pictures of the patient during hospital stay. Here we can see in the first picture that the patient was kept on prone position on day 4. The patient was weaned, extubated from ventilatory support, extubated and taken on BiPAP support by day 6, and patient was further weaned and taken on HFNC support by day 8 and taken on room air by day 11. This patient is now planned for discharge on maintenance therapy with prednisolone and azathioprine. Now, I would like to invite Dr. Tushita Lakhera ma'am to discuss the literature of idiopathic pulmonary hemosiderosis.
So there is no diagnostic test to say that it is this condition? It is the diagnosis of exclusion only?
Yes, sir, it is the diagnosis of exclusion, and it is supported further with the bowel cytology.
Okay, so thank you, Dr. Shipra. Good morning to all esteemed dignitaries, faculty members, and dear residents. I am now going to review some of the existing literature on idiopathic pulmonary hemosiderosis, and that should hopefully rest some of our queries. So this entity of idiopathic pulmonary hemosiderosis was first described in a post-mortem lung biopsy back in 1864 by Rudolf Virchow. He is the same name behind the Virchow's triad of venous thromboembolism, and amongst numerous other discoveries and descriptions given by him, he had identified these hemosiderin-laden macrophages as brown lung induration at the time. Now, IPH, I'm going to refer, in the interest of time, I'm going to refer to idiopathic pulmonary hemosiderosis as IPH. And this is a fairly rare disease affecting primarily children, but a handful of cases have also been reported in the adult population. Amongst children, the incidence ranges from 0.24 to 1.23 per million per pediatric population per year, and owing to again the handful of case series, the exact incidence amongst adults is unknown. Now, given the rarity of this condition, oftentimes there will be a delay in diagnosis, as in our case there was a delay in diagnosis of almost 15 months before he presented to us with this life-threatening bleed, and this causes significant distress amongst family members and patients themselves. So it is vital to understand that IPH can essentially affect individuals at any age, including pregnancy, but again reiterating the fact that it primarily affects children under 10 years of age, specifically between 1 to 7 years. Studies don't really suggest a gender predilection. However, some have quoted that a male sex is associated with worse outcomes. Our patient was a male. There is no known data on the geographical and racial distribution of the disease. So oftentimes, in fact, IPH itself is characterized by repeated episodes of diffuse alveolar hemorrhage, who will present with the classical triad of anemia, hemoptysis, and bilateral radiographic chest infiltrates, as it did in our patient. But what's important to understand is that this classical triad is infrequent, and oftentimes these patients may present with isolated anemia or isolated hemoptysis. And again, anemia alone with mild respiratory symptoms may lead to misdiagnosis, as evidenced by our case. He had multiple admissions for anemia, required recurrent blood transfusions, was evaluated extensively for the cause of anemia right from an HPLC to a bone marrow biopsy, and yet there was a delay in diagnosis because hemoptysis was not really his primary complaint in the past admissions. Coming to hemoptysis, it's important to again understand that in the pediatric population, children will often swallow their sputum. So this may not be the presenting complaint in almost 50% of cases. In adults, however, this can present in 80% of cases. Some other complaints that these patients might come with is cough and dyspnea, and as you can see, all of these complaints were actually present in our case when he manifested. Now, owing to the proposed immunological basis of IPH, we might find a personal or a family history of allergy or autoimmune diseases. I will be alluding to the etiopathogenesis to make this point a little more clear. So despite the long-standing disease identification, the etiopathogenesis and risk factors of IPH remain an enigma to clinicians. There are various hypotheses that have been suggested to explain the pathogenesis of IPH with varying degrees of supporting evidence, and we look at each one of these. So the first hypothesis that there may be an underlying genetic predisposition for patients with IPH was hypothesized in 1970s when it was noticed that case reports had familial clustering, and this was found to be reported between dizygotic twins. Very recently, a retrospective study has also suggested that there is a higher incidence of IPH in patients with Down syndrome. Now, with all the significant leaps that we've taken in the field of genetics, we still haven't been able to identify a specific genetic locus for IPH, and perhaps the familial clustering is secondary to environmental exposure. And not mentioned over here, but as we know, Down syndrome is associated with other autoimmune conditions, so immune dysregulation could perhaps be the cause for higher incidence in this particular cohort. The second hypothesis is the allergic hypothesis, and this stems from the isolation of cow milk specific antibodies, both IgG and IgE, in patients diagnosed with IPH. This entity of cow milk specific protein allergy with IPH is termed as Heine syndrome, and this is very rare. It is not present in majority of patients, even in the pediatric population, and so it is hypothesized that this could be more likely a coincidence rather than an association. That brings us to the third hypothesis, that is the environmental hypothesis. So back in 1990s, there was clustering of cases in Midwestern US, specifically in the Cleveland area, and epidemiological studies done in this area suggested the growth of a toxigenic mold that goes by the name of Stachybotrys cartarum in all of the households of the children that were affected. Now, this mold produces a toxin called satratoxin that inhibits collagenesis and angiogenesis in the alveolar capillary unit, and that perhaps was hypothesized to be the cause of pulmonary hemorrhage. But there hasn't been any report of similar environmental exposure leading to IPH in the adult population, and exposure to satratoxin causes nasal and tracheal bleeding in animal studies, but not so much of a pulmonary hemorrhage. Now coming to the most promising and widely accepted theory of immunological basis. Now I'm going to go through each of the supporting evidence. This is going to be a bit long, so please stay tuned. The first evidence in support of this is that histopathological studies of lung biopsies from patients of IPH in some cases have revealed alveolar capillary basement membrane abnormalities with immune complex deposition. The second, as even evidence from our case, our patient responded very well to methylprednisolone and cyclophosphamide. So there is a clinical response to immunosuppressive therapy that might indicate an immunological basis. And many studies have suggested, in fact have observed presence of autoantibodies in many patients. Very recently, there was a French registry of rare pediatric lung diseases called RESPI-RARE, which studied a cohort of 25 children with IPH and followed them up for a median of 5.5 years. And they found that about 17 of the 25 patients had autoantibody positivity at diagnosis, and 6 of them developed autoantibodies during follow-up. So 92% of the patients in this particular cohort actually did have autoantibodies. Now, evidence incompatible with this is that although there have been some rare reports suggesting immune complex deposition, this has probably been done in the background of a rheumatological disease like ANCA-associated vasculitis. So, considering them to be a part of idiopathic pulmonary hemosiderosis is not really confirmatory. The histopathological studies from patients with idiopathic pulmonary hemosiderosis has revealed non-specific abnormalities that I will be alluding to in future slides. And although many patients do present with autoantibodies, not all of them present with autoantibodies. Now, there have been certain other autoimmune conditions which have been associated with idiopathic pulmonary hemosiderosis as well. 2 of them have been mentioned over here. These are the most widely reported ones. The association of celiac disease with IPH is a known entity called Lane-Hamilton syndrome. And what's interesting is that a gluten-free diet in these patients has helped relieve not only the celiac symptoms but the respiratory symptoms as well. And then rheumatoid arthritis has also been associated with IPH, and anti-CCP antibodies may correlate with lung disease severity. So these were the most widely proposed etiopathogenesis so far, but then what answers our question of immune non-specific abnormalities, absence of autoantibodies, and why are these patients improving on a gluten-free diet if they do have celiac disease? So very lately in 2022, a new immunopathogenic hypothesis for diffuse alveolar hemorrhage in IPH was proposed. I'm going to touch on this very briefly because there's not enough data, but this basically suggests that on allergen exposure like gluten or cow milk protein, some individuals who are genetically predisposed may mount an aberrant immune response resulting in T lymphocyte activation, which results in a cytokine storm and release of bioactive proteins such as histamine, vascular endothelial growth factor, and eosinophilic cationic proteins. These in turn are going to increase the vascular permeability, going to cause vasodilation at the level of the alveolar capillary membrane unit, and that's going to result in extravasation of the deformable RBCs into the alveoli, perhaps resulting in recurrent episodes of diffuse alveolar hemorrhage. This hypothesis does explain why gluten may be the trigger that causes diffuse alveolar hemorrhage. This also explains why immune complex deposition is not a part of IPH, and this also explains why autoantibodies may not be causative. Okay. So now talking about the lung damage, all we need to understand is that the main culprits for lung damage in IPH is going to be the free iron and free heme that is released as a consequence of repeated episodes of diffuse alveolar hemorrhage that will cause lung fibrosis and end-stage lung disease. The free iron that will be released will be, of course, stored as ferritin, and when the ferritin molecules saturate, they will either be released into the blood, and rest of them will form aggregates of hemosiderin. And what we need to understand is that hemosiderin is a form of iron that cannot be utilized by the body, so this results in iron deficient states. So the diagnostic algorithm, all we need to understand here is, as already alluded to previously, this is a diagnosis of exclusion. So before making a diagnosis as such, we have to rule out all other competing diagnoses of pulmonary hemorrhage such as infections, rheumatological conditions, drugs and toxin exposures, cardiac causes, as well as bleeding disorders, which we did. Now, lung biopsy is a controversial matter. It is required for the definitive diagnosis of IPH in adults, but given the fact that this procedure does not come without risk, in the pediatric population, a constellation of the clinical symptoms with radiological infiltrates with a bowel suggestive of hemosiderin-laden macrophages is enough to make the diagnosis of IPH, of course excluding other competing causes. Now, coming to the diagnostic challenges, as alluded to previously, there is a diagnostic delay of almost 1 to 6.3 years owing to the rarity of this condition, its insidious onset and lack of awareness. Oftentimes, iron deficiency anemia can mask the diagnosis, as in our case, and hemoptysis may not always be present. For our case, the delay in diagnosis was 15 months. Just like all other vasculitis, treatment is divided into remission, induction, and maintenance. I just want to emphasize that there are no international or national guidelines on the management of IPH because the causality is not established, but most clinicians will prefer using corticosteroids to induce remission, and in refractory cases as ours, we can also go ahead with cyclophosphamide. Maintenance can be done with steroid-sparing agents. We have put our patient on azathioprine. This is a very recent case series of rituximab that has shown promising results, but it's only 2 patients. Some emerging therapies are liposteroid. This is a liposomal incorporated preparation of dexamethasone palmitate that enhances steroid accumulation at the inflammation sites. Mesenchymal stem cell transplant is still experimental, but it has immunomodulatory effects, and it's promising but not yet the standard of care. ECMO just acts as a bridge to transplant or treatment response, and lung transplant, though it is the last resort, its outcomes remain poor because there has been disease recurrence in all cases with lung transplant. Now, prognosis wise, either there's going to be death from an acute respiratory failure in the setting of an acute hemorrhage, or there's going to be chronic respiratory failure due to pulmonary fibrosis. Children have a mean survival of 2.5 to 5 years after diagnosis, and in adults 14% died during the acute phase, but some have survived over 40 years with treatment. With such morbid numbers, I just want to mention that the overall survival is improving with early identification of the disease and early initiation of immunosuppressive therapy. Thank you.
So I'll just take you through why we decided to have this case, because especially it's for the young residents. You need to understand, because this child had presented to a tertiary care institute. He was admitted in the tertiary care institute twice because the child had anemia, had the other thing was hemoptysis. Just 2 small things that the patient had, and he reached the tertiary institute, and the tertiary institute continued to investigate for routine disorders. So one thing that you need to understand, that yes, think common diseases first, but at the same time, if you have a child coming you or revisiting, or a patient revisiting you with the same symptoms not improving, think of a possible rare disease. So just a small clue, yes, think of a rare disease, 1. Number 2, another message that we wanted to deliver was that rare disease management is still possible, because by and large most people have a thought block that rare disease means expensive therapy, because the way it's hyped in media and other places that you need a lot of gene therapy and gene editing and other things which are costing crores. Here you have a small intervention. We use methylprednisolone, we use cyclophosphamide, and we improved the patient. So not all rare diseases are not treatable, they are treatable. So that's kind of a positive thought that you need to understand. Number 3, why I again wanted to emphasize is that each one of our consultants would be seeing at least 200 rare patients every year. They need to be sensitized to understand that yes, we need to collect the data and create a pool, because most information is not available. Even this case, if you imagine 1 in 10 lakh, that means you have, the whole country will have hardly say 25-30 patients. But yes, if you build the data, you are going to contribute a large to the society. Another important thing that I wanted to highlight, the need of teamwork, and that's exactly where, because we got this patient in the emergency, I had a team of good people who could handle, and we could still transfer the patient to this extraordinary PICU that we have here, which supported us, and we could get the investigations done at MGH. So a strong teamwork helped the patient survive. So the messages are, you need good teamwork, you need to be sensitive, and you have to understand rare diseases are treatable. Thank you.
Thank you, thank you. Yesterday, the Nobel laureate in his lecture made a sentence which I liked. He said, cells talk to each other. I would request departments to talk to each other. I request all departments to have at least 1 or 2 interdepartmental academic sessions. Please, no need to respond. This is not for you.
No, I'm not responding, sir.
Yeah. So that residents are exposed to the related specialities as much as possible. Thank you.
No, we just wanted to acknowledge, because before we end, the management of the Mahatma Gandhi University of Medical Sciences and Technology, led by both our ML Swankar and Vikas Swankar, they've been big support. Sir, you've been big support to us. The Department of Pediatrics, Rupesh is here, I believe. He supported us, and the Division of Pediatric Critical Care, Roop, was very supportive. Department of Pathology, Radiodiagnosis, the CCR Review Committee, Dr. Jaiswal is unbelievable, because he really transformed. He gave us a lot of time, and he made us understand how to do good things. And the nursing staff, as well as the patient and the family. Once again, thanks.